And we're going to not give you a lecture with lots of data and lots of theory. That's interesting in this area too, and we could have done that. But instead, we're going to show a few slides, and we're going to try to leave more time to interact with you around a number of the strategic questions that we are hearing about or that we understand that you're facing. So this is what I'm going to do in my 10 or 15 minutes. I'm going to talk in just a dozen slides about why we think health insurance or risk pooling is a huge strategic opportunity for all the countries that are here. Look at some of the big choices where your strategic problem-solving method can be applied and is being applied one way or another every day. Whatever you may be learning here, you wrestle with these strategic choices in your jobs. Speak a bit about what some of the challenges and solutions might be around health financing and insurance. Mention a couple of the more promising experiences that are occurring right now. There is an important process of experimentation, and a lot of information is being generated that can be revealing and helpful to you, and then put out some questions. And I think that it's maybe it's just a lucky coincidence, but it struck me as I was preparing for this talk that we have here among the 5 delegations 2 countries, Ghana and Rwanda, among the low-income developing countries that have been the boldest and have gone the furthest in experimenting with health insurance. Ethiopia and Liberia perhaps working in this area, thinking about how to go forward, maybe some questions and some issues that you have where your colleagues from Ghana and from Rwanda can provide some lessons. And I know in Mexico, having worked there, and Dave having worked there as well, that Mexico has been wrestling for many years with the questions of health insurance and so-called universal coverage, starting from a different historical and traditional point of view, but with some of the same issues. So I think this is a problem that unifies all of us, that brings us together. Just to recall some of what Ariel Pablos Mendez and others presented over the last couple of days, some of the problems in the developing country, and I'd say in all country health systems, where risk pooling and insurance can be seen as part of the response. First of all, in many cases, most cases, government revenues historically have been channeled exclusively to government health services. The government collects the money, it then distributes it strictly to public sector providers, salaried doctors, a whole series of expenditures within the public system. This creates a certain number of opportunities, but also some problems, including the fact that from the patient's point of view, there may not be a choice of providers. There may not be the competitive pressures or the incentives for good performance. We were talking over lunch, Mexico. I was listening to a very interesting discussion between Mexico and Rwanda about pay for performance and how to, within what's essentially a public system with public money and public provision, how to try to somehow incentivize higher quality performance. And even some mention that in Mexico, separating the paying from the providing side of the equation has been part of what Mexico has been trying to do. That, in a way, is setting up some of the dynamics that we see with most insurance systems. Thirdly, in these exclusively public collection, public provision systems, there's no opportunity for the private providers. These may be NGOs, religious organizations, or for-profit providers to participate and actually be a part of the challenge of providing the essential services to low-income families to help achieve the national health goals, to help achieve the Millennium Development Goals. And yet we know that in many of the countries here today and all around the world, as important as the government is in delivering health services, there's just a rich array of private providers out there in almost every country. Sometimes the government pays attention, sometimes it doesn't, sometimes it knows what's going on or it doesn't. But this is a tremendous asset which governments often don't harness in order to achieve national health goals. Insurance may be part of the answer there. And secondly, everybody's been talking about this issue of out-of-pocket expenditure and it's almost become the evils of out-of-pocket expenditure. I think there may be some good things about it, but largely it's been characterized by the speaker so far as the big problem that needs to be addressed. Because indeed, it does expose people to catastrophic expenditure when they're not covered by some kind of risk pooling arrangement. They have to pay for quite costly medical expenditures. And typically in these kinds of systems, I think somebody yesterday was talking about benefit incidence, looking at really where the government is actually spending its money, and maybe that was you, and remarking that even in these purely public systems devoted to helping the poor, it tends to be the better off segments of the population that capture a lot of that public expenditure, the incidence of public expenditure. And what happens with the lack of out-of-pocket is that poor households pay a large amount in absolute terms, but certainly as a percentage of their income, it's almost always larger than the share of income for the wealthier, what did you say, quintiles, I think. You were talking in terms of fifths of the population. And you saw this yesterday, this slide that Ariel put up. I'm not going to run through it again, but I think as he characterized it, as imperfect as these data are, and I wouldn't get carried away by this one or the next one that I'm going to show you because a lot more work needs to be done. The kind of the broad color-coded goal here over time of having more health insurance is to turn more of these light blues and whatever, basically the lighter, the very light blue and the medium blue to turn it black, because black here is good. Black here means lower level of out-of-pocket expenditure. The inverse is higher levels of health insurance coverage. This was the other slide, I think, that Ariel showed. It's a little counterintuitive here because we get the same countries in black in both senses, but in both of them. But here, this is the inverse. These are the countries where at least the ILO, according to its data, is saying that there is a high degree in the darker shaded countries, a higher degree of coverage. And I would have thought, where's the Rwanda delegation here? Oh, over there. I would have said, I know Rwanda's a small country right up there, but it should be black, I think, because you were just telling me that Rwanda, and I have some slides actually later on, just one slide, showing that coverage is very, very high now in Rwanda through its health insurance system. And I think Ghana, also through the NHIS, about 60% of the population, I believe, is covered now, and there's an ambition to go much higher. So I think this map is already out of date. There are two outstanding African countries. And I think Mexico, that's probably fair. Mexico has a high degree of coverage, especially through Social Security. So this is the central thesis that I'm putting out there that we can debate. It's not without its controversy, but this is the grand strategic opportunity that I'm putting out there for you to consider, which is that health insurance, risk pooling of one kind or another, and there are many different variants on how to do health insurance and risk pooling, that it drives a whole series of changes throughout the system that have an impact on health status and that have an impact on the rest of the dynamics of the health system. That is maybe a bit of a bias of somebody like myself who's an economist, but I think that there's a lot of evidence that money here and the way in which funds are collected, the kind of protection and risk sharing that's driven or that's afforded through health insurance, it actually has a whole series of concatenating or repercussions throughout the health system. Some of them, I think many of them very positive, some of them perhaps that could be negative and that need to be managed, but that it's a very powerful instrument for driving change in health systems. And whether you want to look at the impact that it has on the financial protection and the health of the population, or the catalytic changes in the systems itself, that it's a very, very powerful driver, and one which needs to be very carefully designed, carefully managed, in order to achieve the positive impacts that it can bring, and in order to mitigate or avoid some of the downsides. And there are downsides to every policy change, whatever might be its upsides. But reducing the out-of-pocket expenditures and this risk of catastrophic expenditure, which drives families into bankruptcy or into poverty, is certainly one of the very powerful dimensions of this. Using health insurance in a very carefully designed way to increase utilization of health services, and hopefully health services that really make a difference to health outcomes. I think, again, over lunch with the Rwanda colleagues, there was a lot of mention, I believe you mentioned, that you noticed in your own practice that with the advent of health insurance or the expansion, that the numbers of people coming in and demanding services had gone up twofold, or you said from 40 patients, you gave the example of 50 would show up now, and you attributed a lot of that to the financial security that came out of health insurance. Of course, the next question is, what are they coming in for? What types of health issues are they coming for? Not that all of them are not valid health issues, but in terms of some of Rwanda's basic health goals around reducing maternal mortality or child illness and child mortality, infectious disease, are people coming in and demanding and receiving good quality services to deal with those health problems that the country sees as being central. In terms of the catalytic changes in health systems, we can talk about that during the discussion period, but because of the way in which insurance allows for a separation of provision and financing or purchasing, and creating what I call here a platform for strategic purchasing, there are a whole series of things that can be done in terms of trying to achieve national health goals. It can give patients more of a choice of their provider. It can bring in private NGO and other non-state providers in a way that wouldn't be possible otherwise. It can be targeted toward essential services that have a large health gain behind them. Certainly it can be used also to try to promote the equity objectives that governments see as part of their responsibility, to try to preferentially serve the needs of those who are most disadvantaged. It can certainly incentivize quality, and we talked about that a bit over lunch. The Rwanda example may not be easy to translate into Mexico. There may be special reasons why it can't just be carried and plopped down in one of the states in Mexico, but there may be some ideas there that you can grasp that can be useful. And certainly, to the extent that, as I say here, money follows the patient, expressing both the demand or the need of the patient, the opportunity or the stimulus to make providers accountable to patients for what they do in terms of timeliness and quality and other things like that, as well as outcomes. Insurance may be a very important part of the answer. In terms of the changes and the choices, this is a very stylized look at how health financing and health insurance evolves over time. I think there was another version of this shown by Ariel yesterday, but this is an adapted version of it. If you compare a number of the countries here today which have modest incomes per capita, say $500 to $1,000 per capita, which I think is the case of many of the African countries here, a relatively small share of GDP or of national wealth going into health, around 4 to 6% typically. So these boxes ought to be smaller in volume than the ones on the right, because as Ariel said yesterday, as countries' economies grow, the share of national wealth which goes to health tends to rise over time, the sort of iron law that he showed with those graphs yesterday. But typically, it's the out-of-pocket expenditure that predominates. The government is a large financier, and then you tend to have smaller amounts of either social health insurance, where I think this is the Mexico experience, covering about half of the population, where payroll taxes are used, both employee and employer taxes are put into a pool and cover those who actually contribute, maybe not the whole population. But you have this as an important way of pooling risk for a part of the population. It tends not to necessarily be a universal system in most developing countries, with a few exceptions, like Colombia. And I guess Colombia is the one that I would cite right now. And then you have the community health insurance using local mechanisms for collecting and often retaining at local level premiums, sometimes subsidized by the government, in order to, again, pool risks, but typically across a smaller population group. But where this would be for most of you here, what are the choices you face going forward? Typically, as you move toward health insurance and risk pooling, the share of out-of-pocket expenditure goes down dramatically. Private health insurance may come in a modest or a larger way. But in most OECD countries, in most developed countries, private insurance tends to be small and supplementary to the larger national systems, which tend to be either on the National Health Service model along the lines of what was developed in Britain after the Second World War. I believe that one of the speakers yesterday referred to Beveridge and the National Health System. And then there's the tradition of the social health insurance models, which much of Latin America has picked up over the last century. But I think in many ways, the historical antecedents there come out of Germany, out of the Bismarckian period at the end of the 19th century. And that model, based on wage taxes, has been picked up in a number of the European countries, such as the Netherlands and a few others. And this tends to be a choice rather than a both. It's an either or. And that's been historically the pattern. That doesn't mean that the countries that you come from may develop some different system or some hybrid, but those are typically the models that countries have moved toward over the last century and a half. And as I said up here, a much larger share of national wealth, which is also growing by definition, going into the health sector. So the choices facing low-income countries, and I would say middle-income countries like Mexico. Mexico is typically classified by the International Monetary Fund and the World Bank as a middle-income, very solidly middle-income country with per capita income perhaps 5 to 10 times what it is in many of the other countries here today. But still, I would say in general, the questions tend to break down into these three areas. First of all, are we ready for social health insurance? Is there the political momentum? Because this is not just a technical decision. This is very much a political decision. I was hearing again from Rwanda. I'm sorry if I keep mentioning Rwanda, but there are some historical circumstances, some of them not very pleasant in the country's history over a decade or more ago, that perhaps the positive side of that is that it's led to a very strong political consensus and political will to deal with some of these issues like health insurance. So each country faces a different set of historical and political antecedents, but there has to be at least a conversation and a decision at a high level to move toward this, because this is not just a health problem. This is an issue that concerns the whole ministries of finance within government tend to and ought to pay a lot of attention to what happens in health insurance. It can have a big impact on employment if you use wage taxes. It has many, many effects, and of course, it has a very large impact on the whole medical care sector. And there are a lot of vested interests that may or may not want to see the kinds of changes toward health insurance. Not everybody will necessarily benefit from the creation of a national health insurance of one kind or another. Secondly, what kind of system do you or do we want to pursue in the long run? And it tends to break down into three key areas. Where is the money going to come from? What's the source of revenues? Is it going to be general taxes, these wage taxes, local premiums paid out of pocket, at least to finance a part of it? What's the mix? Where's the money going to come from, and how is it going to be pooled together? Secondly, how many purchasers and what type of purchasers are we going to have? In the German system, it's a decentralized multi-payer system. It's not a single government. It's not the German government collects these wage taxes and pays all providers. It's a decentralized, subnationalized system with a number of different purchasers. They may compete, they may not compete. So that's another big issue. And then the third one is who in this kind of system is eligible to provide the health services. Is this going to be a publicly delivered system, a mixed system, predominantly private? A lot depends on the starting point for each country, and again, these political choices. And as I said earlier, at least to stylize the choices that you face looking at what's happened historically, not that you have to be a prisoner of history here by any means, but there are the national health system or national health service type approaches tending to use general non-earmarked taxes or revenues, largely public provision. That's the UK system. Then, of course, the social health insurance model that I mentioned before, I referred to Germany, but it's also the system that Korea very consciously copied about 25 years ago and now has in some ways, a very successful health insurance system. In many ways, it was the inspiration for what's happened in Colombia over the last 15 years as the country perhaps in Latin America that's gone the furthest with social health insurance. And I say half of Mexico because I believe through the two big social security institutions in Mexico, about half that population is covered. But still, there's this anguished concern. What about the other 50%? What kind of service do they get? And is it fair? Are they getting good quality services? How do we improve the protection and the health services for the other 50%? And then finally, you have some private insurance options. The U.S. and Brazil to a certain extent, Switzerland to a certain extent, use certain forms of private health insurance. It also has a certain number of advantages, but it also has a number of disadvantages. Certainly, the ability to achieve the kind of universal coverage that's implicit in what many countries here want to do would suggest that the approaches under private health insurance have some very serious drawbacks. So the other big question, first you have to ask the question, where do you want to end up? What kind of a health insurance system do you want to have? 10 years, 20 years from now? I don't know, Betsy, most of your problem solving was 1 to 3 years. So, and that may be the political lifetime of many of the policymakers that you know in your countries and that we know in ours. Moving to a large health insurance system is almost certainly going to take more than 3 years. So maybe in terms of the methodology you were taught yesterday, it's also important to think in terms of stages and some intermediate milestones along the way. Not that we can ever predict exactly how these things are going to evolve, so adaptation and adjustment are also important. But the other question is, how do we get from where we are today to where we need to go with health insurance? And I think that the most important sort of lesson that's been learned there is that you can end up in almost any number of places from whatever your starting point is today if you know where you want to go. But it makes sense to try to build on what is out there already, because where there are community health insurance schemes like in Rwanda, or social health insurance schemes as in other countries, it's easiest to build on them. Then there's the question of the scope and the pace with which you move. There are options. You can go slowly and expand coverage very gradually. That may risk some type of political reversal. You can also go for the big bang and try to change things very rapidly. That can be messy, but it also gets you there faster, and then you can sort out the other issues that arise under those circumstances. There's also the question of the affordability of what you want to guarantee as the benefits package that you're going to cover. And this is where a number of countries have really run afoul. And I'm not just talking about low-income countries. I'm thinking, for example, of the Czech Republic after the liberalization there in the early 1990s, when a very generous health insurance package, which was paid to doctors on a fee-for-service basis, very quickly bankrupted the Czech health insurance system, which was paid out of wage taxes. So the size of the benefits package and how you pay for it are very, very important. And then there's the issue of whether this is going to be done largely with domestic resources or whether there'll be a mix of domestic and external support. In terms of some of the stumbling blocks, I mentioned them earlier, so I won't go through them in any great detail. But again, that's the trilogy that I would suggest you think about: revenues, the benefits package, and the issue of the payment system that underlies it. Because each one of those can either make a health insurance system sink or swim. And as there are many ways that a health insurance system can come crumbling down. Many, many ways. It's not easy. It's worth being vigilant and thinking through all of these risks as you go forward. In terms of solutions, again, there isn't time to go through them all. We can pick them up in the discussion. But whether it's in the revenue area, the benefits package, or payment systems, there are solutions which have been developed and implemented and have worked well in other countries. So my suggestion, without going through each one of these, is your country is unique. It can't necessarily assume that what happens somewhere else will be applicable, but it's worth learning the lessons of what other countries are doing. And in that sense, again, it's great that Ghana and Rwanda are here. If there were more time, Betsy, we could almost have an entire week just talking about how to reform health financing. And getting the different countries to talk to one another would probably be a lot more worthwhile than listening to me blabber on about what I know, because each country here telling each other about its experience could probably maximize the learning and the ability to formulate responses. I say that this is not a blank slate, and I think it's important that among the low-income countries that have really advanced dramatically in this area, two of them are here in the room, really two of the outstanding examples that we, in Results for Development, when we've documented innovations in health finance, we constantly come back to Ghana and Rwanda. So I feel very honored that I'm here this week with those two countries because they really are the pioneers. Ghana with its national health insurance system, Rwanda building up on the mutuelle, the small, locally sort of autonomous systems which have been brought together and woven together in a national system. How they started small and got big, perhaps they can tell us about in the discussion. But there are also other countries that are not here. Nigeria, which has some very interesting experiments right now using HMOs, health maintenance organizations. India, which is itself a vast laboratory for experimentation in health finance. It's unbelievable. It's like a continent or a planet unto itself when it comes to things that are going on right now in the health insurance area. We can't keep track of them all. We've been trying to monitor them. But there are a huge number of things going on there. And I did want to mention, although Mexico is a middle-income country, I put it here at the end because Mexico, under its recent health minister, Julio Frank, has made a very bold move to create a kind of insurance for the 50% who are still not covered by Social Security. Whether it's the perfect solution, I know that from talking to the Mexican delegation, they're struggling with how to improve the use of this people's insurance. That's what Seguro Popular means in Spanish. It's not the story is not at its end. It's perhaps at its middle or its beginning. But I know this is something you're working very hard on. This was the Ghana system. I'm not going to run through this, but Ghana collects the money up here at the top through a number of different channels, including wage taxes and value-added tax. So it's a mix of general taxation or at least taxation on consumption across the board and individual wage taxes. It also has small user fees, and it also draws in premiums that are collected through other sources. And then it uses it to allow patients to go to a mix of public and private health facilities. In the case of Rwanda, I said I would at least show one picture. It looks like I need to add another dot somewhere up here because you were saying now that Rwanda is up to 95% or 97% coverage, but this is almost unprecedented if it's true, if it can be verified, and if this is really leading to the kind of social protection or financial protection that health insurance can give. This is quite a remarkable expansion of the insurance in Rwanda. In terms of some of the lessons learned, just to finish up, these are broad generalizations. Each one can be questioned and challenged. I would do the same, but certainly what you start with, the voluntary and the community-based financing systems can help to build confidence in the larger prepaid schemes as people get used to participating and to contributing something. I think it's $2 per person in Rwanda. It's not a huge amount of money, although for some households that might be considerable. This is a way to build public interest and support. The key thing is to pool risks, whether it's through the social health insurance approach or the national health system approach, may be of less importance than the political decision to move to this type of universal coverage and to go at it in a systematic problem-solving way, because problems will come up along the journey no matter how well you plan ahead of time. As I said earlier, my three little trilogy, make sure the benefits package, the revenue collection, and the payment are very carefully examined and managed, because that's where these systems tend to rise or fall. The political commitment, that's very clear, but also the management and administrative capacity to support these systems. That's what many of you here are so good at. Evaluate at each stage and keep adapting. And don't forget that overall, as Ariel said yesterday, if the country's economy is not growing, it's very hard to put any type of a health insurance system in place. I know you're not the ministers of finance or economy, but it does matter. So this is where I'm finishing, just with some questions that we could take up in the discussion. For Ghana and Rwanda that have already traveled far with this, maybe you could talk a little bit about the most difficult problems. We know you've done a lot of good things, but what are the big problems you face? Can you share with us what worries you about the progress you've made, and whether there may be some backsliding, and whether there's some new issues which have come up, and how are you dealing with those? For countries like Ethiopia and Liberia that are here, what are your plans in the health insurance area? Where is the country going with this? And what are the big questions and worries you have where perhaps the others can be helpful? And then I say here, this was written, I think, before I had lunch today, and I wrote down, are there lessons from the reform of the social health insurance system and the Seguro Popular in Mexico that could be useful for the African countries? What I heard over lunch was the reverse. I heard Mexico mostly listening to Rwanda and trying to get some clearer ideas about how to put in place this performance-based financing. So it's really a two-way street here. And finally, just to end, what can Yale faculty and external partners like ourselves do to help you to try to deal with some of these problems? Because that's our job, that's what we're here for, to learn together with you and to try to advance your agenda. Thank you.